So good evening, everyone. So today we are welcome everyone to the inaugural episode of IATS Academy's PG webinar series. And this initiative was taken by our president and Ranjit sir, who was the chairman of PG committee of IATS, Dr. Bhuwan Singh sir, who is the secretary of the IATS at the last IATS con at Patna, Bihar. So the whole idea behind this is to educate the postgraduates with relevant topics regarding their exams, practicals, and all of those things. So accordingly, we will select the topics in further episodes. So we are privileged to have our executive of IATS with us, Dr. Bhuwan Singh sir, our secretary, Ranjit sir, our chairman of the PG teachings, and IUA secretary, Dr. Rajeev Raman sir, who is also the national advisor for this IATS Academy. So to begin with, I will hand over to Dr. Bhuwan Singh sir, just to say a few words about this initiative of his. Sir.
Good evening to all. Welcome Dr. Ananda Pal sir, Dr. Lalit Maini sir, Dr. Magu sir, Ranjit was and everyone. This is a platform for the Postgraduate Orthopedic Association and Research, Education and Research. Our primary aim is to support orthopedic postgraduates in their academic and clinical training. This program is designed to enhance your understanding of key topics relevant to the exams of PGs and DNB. We are committed to helping you develop clinic decision-making skills and comprehensive understanding of the orthopedics. This is my message, my mission, and my aim. And now over to Ravi.
Thank you, sir. So I would like to have few words from Ranjit sir. Sir, he is the chairman of our PG teaching committee of IATS.
Thank you, Ravi. I welcome all the faculties, including Dr. Maini and Dr. Paul, a good friend of mine for years. And the whole idea of this PG teaching is to train our PGs so that they can do well in exam. Not only that, to train them clinically so that they can diagnose, treat the patient efficiently, and that and to create a wholesome insight into how to tackle the cases, how to see patients, how to examine patient. The whole idea is that. And for that, we have selected, and we will be selecting stalwarts teachers from across the country. And we have selected, and I've been requested, and he's here, Dr. Paul. I welcome him. I think that will be a very good, initial teaching tricks and understanding how to see patient, examine patient, and appear in exams. So let us see how the things roll out. Thank you.
Thank you. Thank you, sir. So now I hand over to Dr. Rajeev Raman, sir, who is the national advisor for IATS Academy and as well as the secretary of Indian Orthopaedic Association. To you over, Rajeev, sir.
Thank you, Ravi, and welcome all. And I would like to thank Dr. Bhuwan Singh, Dr. Ranjit Singh, Dr. Sudhir Kumar Singh for this wonderful initiative under aegis of IATS. And today we have eminent speaker, Professor A.K. Pal sir, who is my teacher and mentor also. And I was blessed to be his student during my postgraduate day in Bardhaman. And right now he is Professor and HOD of Jalpaiguri Medical College. We have an expert panel, Professor Dr. K Magu sir, who is ex-HOD of Rohtak Medical College. Professor Dr. Lalit Maini sir, who is Professor and Director Professor in Maulana Azad Medical College. And he has been conducting this PG teaching program in DOA and IUA for a long time. And Dr. Jayant Sharma, I think he has not joined. He is Professor in Orthopedics in Index Medical College in Indore. So without wasting the time, I think we will start the meeting and I will hand over to Professor A.K. Pal sir, who will be talking on how, what, when to read during orthopedic residency. And at the end of the talk, we will have an interactive session with expert panel and also postgraduate residents. Thank you.
Thank you, sir. Paul, sir, hand over to you.
Thank you. Thank you, Ravi. This is an excellent initiative, I think. And this is the first time it is a platform where we think of our next generation. I'm extremely grateful to these IATS who thinks of our next generation for development of postgraduate education and research. So basically, this is a first talk. I'm honored to have this first talk, what, when, and when to read during this post-graduation the residency. But there are several other topics we'll discuss, and this is a continuous process. So teaching is a dynamic process. Teaching, learning is a dynamic process. I'm also here to learn from our experts panel. So there are several topics. I think there is it continued. So how to make a blueprint or plan for 3 years course, how to clinically assess and analyze the cases, how to be the master of clinical test, how to read and interpret the reports or investigations, how to communicate with the patient's teacher, communication. It is extremely important during the residency as also after that, after course is over. So communication with the patient, teacher, case presentation in group discussion, seminar, journal club, and conference. How to build the technical skill. We'll also here to will convey this message. That writing the prescription, and how to become the master of the semi-invasive to invasive procedure. How to prepare a patient for operation and the counseling, how to report and the keep records, how to make the research, prepare thesis and publication, how to face theory and practical, and lastly, how to become a leader of orthopedic management team in daily practice and disaster. So they see that the once is any postgraduate training, when we enter in this course, there are several books are in the market, and also they may be advised by our seniors, but it is very difficult to understand which books to read. So this is my way. So how to, when, what, and how to read during your residency. Now, the blueprint of the course, basically there are 4 phases of the 3 years course. First is the planning phase, is the orientation phase. So once before that, your life will become changed when we enter in the post-graduation in any course. So the first 3 weeks is the orientation. Next 3 months, it is observation phase, where you have to develop yourself to become the part of a team. Third component is the most important. 3 months from the initiation period to 6 months before final examination. This active phase or the implementation phase. I will discuss what to be done in this phase. And lastly, the examination phase or the evaluation phase. But the last 6 months of your 3 years period, you have to prepare yourself for your evaluation. The planning phase is the first 3 weeks. That means it's the orientation phase. You have to identify the course plan, curriculum, place, and person, and you have to know what is the residual knowledge you can have, and you have to prepare for the second stage. Now there is curriculum. I'm not going into these details of the curriculum, but this 3 years period, we have to become the master of the knowledge, orthopedic knowledge of affect and psychomotor skill. Not only that, we have to become the master of the technical skill, research, and lastly, the professionalism. These are most important. There are several fragmentation. I'll discuss one by one. There are several routines. You have to make your routines, daily routine, weekly routine, examination schedule. You have to know the examination schedule, record keeping, like that. Now, how to learn, when to learn. So from your dawn to dusk, once you start your OPD, once you get inside your course from the OPD, we have to make the OPD notebook. So you have to make your experience of clinical examination. You have to make a emergency activity diary, OT diary, and the follow-up diary. So you have to keep it by your own. Now, suppose in the OPD, you have to find these sort of cases. You have to spot the diagnosis. From OPD, what is the initiative from the OPD? Some OPD, suppose this is the case, we have to know the terminology. So this is the deformity. What is the difference between the attitude and the deformity? The attitude is basically, it is the adoption of a position which is changeable. which is changed. It is temporary adaptation procedure which becomes comfortable. But so suppose it is looks like it is a coronal plane deformity. So is it a cubitus varus? So what is explained? So we have to write it in your notebook. So see this, if you see from the side, so this is the angle. So this is see, if you see this angle, that means extension is not possible. So it is not a actual true cubitus varus. So it is basically, it is a stiff elbow. So it is, so we have to understand what is cubitus varus, what is the recurvatum, what is procurvatum deformity. It may be multiplanar deformity. So everything we have to understand. We have to know the different planes of deformity. We have to know the anatomy and the biomechanics. So it is most important. So suppose this is the case. These are several questions may come. Is it a cubitus varus? No, it cannot be. It is a true cubitus varus. So it is a basically it is a deformity, so elbow stiffness. Now, cause is, we have to explain this relationship of three bony points. Now, is it isosceles, or it may be the two arms is equal in most of the situation. But suppose this is the case, the inner arm may be the shortest arm, the lateral arm may be the intermediate, and the base, that is interepicondylar distance, may be the longest. So there is a irregular triangle. Why it has happened? If it is a long standing, because of the triceps contraction, so there is a growth development deformity, deformity of the medial side of the elbow. So the trochlear epiphysis becomes maybe underdeveloped, so medial arm becomes shortened. So it is irregular. So it is not a fixed. We have to check what is happening. We have to explain everything. This is the knowledge how will you acquire. Now, in the developmental phase, we have to know the course of the institution. You have to know yourself. That is a residual knowledge. Interest and the motivation is extremely important. These are the two very, very important field. There's identify the field of interest, identify the topic of the dissertation. These are very, very big. There's a separate lecture I will discuss in the later one. How to separate, how to select your dissertation. Now, development of course is I have to identify the must know, may know, and the obligatory to know. So what are the resources? You have to do to check the book, journal, teacher, institution, and the conference. Now, selection of the seminar in the journal club. In the first year, you have to concentrate on the basics like pathophysiology of Kerry spine, like that. Pathophysiology of the metabolic disease like the rickets. You have to biomechanics of the hip, like this. Bone healing complication, research methodology, etc. In the second year, you have to concentrate on the management options of the specific trauma and the diseases, specific surgical treatment, assessment of the complications. In the final year, you have to concentrate on the recent advances like the stem cell therapy, like this, management of the complex complications, like the how to manage a failed total hip replacement, like this, super specialty and the techniques. Now, see, this is the another learning. So the implementation phase starts from 3 months from the initiation of your course and 6 months before the final examinations. So in that case, we have to, have the clinical learning, but the actual conduction of the seminar, we have to make a list by make a common fracture, disease, and the operation. And we have to make it again, the routine we have to follow. Now, among the three, so you can ask which one is the ideal position for inspection. So in that position we have to inspect. So everything has a norm. So basic norm of inspection, that is see this patient also, it is lying down on a hard surface, but the limbs are not parallel. But this is the position. This is the ideal position. That is the patient should lie on a hard surface. That the trunk should be straight, limbs should be parallel to each other. It is well illuminated, so that if there is a flexion deformity of the hip is compensated by the excessive lumbar lordosis, that light can be visible between the heart table and the back. Now, this sort of patient, this picture can be given in your OSCE system. And if they mention the inspectory finding like this, so you have to train yourself from the OPD from the very beginning. Now, the clinical learning from the implementation phase is from the bedside clinic, word round, word teaching, word class, case method, group discussion, brainstorming method, and the discussion technique from the conference, symposium, panel discussion, and the guest lecture. Now, this is the very beginning. We have to develop your skill of affect. What is that? That means we have to understand the patient's philosophy, patient's what the patient wants. So you have to listen. You have to learn to listen. So you have to feel the sentiment, sympathize, try to become the part of the patients and the relatives. Don't consider they make a party. They always consider that as a relatives. Don't consider as a case. Consider as a patient. So this is very, very important. You have to reassure in every steps, because every problem has some solutions, and give the judgment which is safest, simple, and the suits best for the particular patients. Think holistically. What is this idea, behavior? What is the occupation like that? What is the ABC? I'm just touching the ABC of good doctor is the ABCs means the availability, B for the behavior, and C is the competency. Competency comes after the availability and the behavior. It is very important. Now the communication skill starts from the very beginning. Once you come in your post graduationship, so suppose you have to go, you have to allowed to become a attend a call book from a ward. So how to communicate with your senior, to your boss, or your your colleagues. Now we have to design this is the is bar. This I for identify, I S for the situation, background, assessment, the recommendation. Now one of the residents, it is like that. There is a person, 65 years, female, admitted in the ortho ward with a progressive hemiplegia. So situation is very urgent. Identification of the yourself and the patient. Patient is this identified. Situation is very urgent. What is the background? She is a case of DVT due to the intertrochanteric fracture femur on Clexen since 23rd January, and the warfarin since 4th February stopped like this. So this is the background. Now assessment, we have to assess whether it is progress, it is improving or deteriorating. Now see, this is last night her motor power deteriorated. So it is a assessment is a grave, and a management, whether it is urgent required or not. Yes, see, it is a management deteriorated to 1/5 left upper limb. Kindly advise urgently. So the is bar is maintained in every. So in this way, you have to train yourself. Now, how to read for the theory examination? See, there are the three types of theory questions, like is it a essay type questions, divisions or segmented questions, or analytic type of questions. Another is the OSCE. I just touched what is OSCE 1. Now, in every theory, so this is the schematic diagram. You have to become the master of to draw the schematic diagram and this sort of chart. As you can see here, this is the schematic diagram of a pelvis, and it is seen it is a Mervyn tile classification. It is a normal pelvis, and so this is the extra-articular only the ring fractures without involving the instability, whereas this is the B1 type, this is the C1 type. Now, the pelvic ring fracture, if you write on this, so it is a simple chart. So it is ATLS guideline you have to maintain like this. It is a very simple. It will took very little time. It is very impressive for the examiner, and it will acquire a high marks. The use of multiple colors. How to use the multiple colors? See, suppose you have there's a classification of the ankle fractures. Now, the different types of classification where it is highlighted is the Lange-Usens classification, as you can see here. Now, there are three types of forces. Distraction force leads to transverse fracture. Rotational force is a spiral type of fracture. And the axial compression force is a comminuted fracture. Now, basically, how do you understand? See, this is the green is it is basically green is over here and over here like this. So basically any type of rotational injury, it starts with the distraction force. So suppose in your think of your hand with a pronation like this. Pronation means the external rotation. So if it is a supination adduction injury, external rotation injury. For in supination, what is happening, there is a distraction force is acting on the lateral side. So this distraction force, the force that starts from the lateral side, that causes a lower fracture, because the starts from here, it ends over here. So it is a very low fracture. Supination, supination adduction injury, it starts by very low fracture in the lateral malleolus. When we come to the medial side, it will go a higher fracture. So starts with the distraction, is a lower fracture, usually transverse, whereas in the end, it is either rotational or is a compression. Rotation causes a spiral type of fracture, axial causes a compression type of fracture. So see this if it is a pronation external rotation injury, so smaller it is a medial malleolus, very small fragment. In the higher, it is in the it is in the fibula, or it may be very high up. It is a Masonius fraction. So in this way, you can use the multiple colors. So, next is how to prepare before the examination, daily routine, and the timer. You have to make list of everything. List of long or short cases, implants, equipments, which is usually required is a basic implants, and the normally advanced, commonly used advanced implants, equipments, and medicines. List for the operations, approach, and the surgical. I will show how to prepare for yourself. List flying the oral questions, emergency situation. A list for the common orthosis and prosthesis. Now, how to acquire the knowledge? So this is the very, very important platform right now. It is maybe very, very helpful before, maybe much more important before the book also, because you can carry with you. So see, first is the Google. Everything everybody knows that the Google is a very, very important search engine. But apart from the Google, so there are several other search engine. So options at the hands of the internet, book, teachers, seniors, colleagues, and the patients. Patients are also very, very contributor for your knowledge. So you have to very much, yeah, very much. You have to become very much attributable for these patients. Now, what are the different search engine apart from the Google? This is a Meta AI, which is attached with your WhatsApp. This is a chat GPT. This is another one. It is a very, very informative, and another is the V Connect. So they can produce your PowerPoint also. This is a very, very important search engine. Now, how to get the exact and the effective information? This is the MES applications. What is MES? MES is basically it is a medical subject heading from the National Library of Medicine. So it will guide you the exact vocabulary. Which exact word if you use in your internet to get the exact perfect publications related with the work. So this is very, very important. And this another important app is the Zotero app, which is a free, easy to use tool to help you to collect, organize, annotate, and the cite and the search for the research, share for the research. So you see there are several steps, this mesh, and even you can also get training from the mesh also. There are several steps you can go through it, and this is very, very important platform. Now, how to start your career to acquire knowledge and reading? So start with the osteology. There are several topics by which you can start: the name, parts, development of a bone, anatomical portion, like that. So there are several books you can see here. This is the most important books. You can see this. This is a surgical exposure. As you can see, this is the most important books, Hoppenfield. Apart from that, this is the Naters. This is the Cunningham's. Grant's, and especially I will mention this is the Grant's method of anatomy. It is a very, very important. It is a extremely it is made in a interesting way how to remember the anatomy. This is my, and also in clinical aspect also. Now, how to memorize? Suppose this is the brachial plexus. Now, how to memorize the different parts of the brachial? I'm giving very, very important mnemonics. So where the life may become very much complex. So what can happen? How to remember is very now is the RTDC. Just remember the art. What is RTDC? Is it the Rajasthan Tourism Development Corporation? Maybe, but you can memorize the mnemonics. Is a root, trunk, there's a division, and the chord. Root is basically 5. So 5363 is very easy to remember. 5 roots. Now it is looking like a horrible situation. Now I'll make your life easier. Now this is very schematic diagram. Everybody can can draw this. So the 5 roots. There is a trunk. These 2 roots, C5, C6 make the superior or upper trunk. C7 contains the middle, and the C81 is the inferior. So these are 3 trunk. Every trunk make have 2 division: anterior, posterior, anterior, posterior, anterior, and posterior. Now this anterior trunk of the superior and middle continue as a lateral. Okay, so there are 6 division, says D for 6, and there are lateral cord. All the posterior branches of these superior, middle, and inferior trunk continue as a posterior, whereas only the posterior of the inferior or the lower trunk will continue as a medial cord. So RTDC is a 5363. Now coming from that, so there are 555. What is given? Why it is 555? So from these superior trunks, from C5, C6, actually they're all C5, C6, C7, and the C81, there are 5 branches. So how will you enumerate? The 5 branches, and that's it, not to suprascapular, not to subclavius, there's a lateral pectoral, there's a musculocutaneous, and the lateral root of the median nerve. Now for the posterior cord. Now see, there are five, again five. This is the terminal branches, the axillary and the radial, and from the posterior another three. There is this is upper subscapular, lower subscapular, and the thoracodorsal, up to thoracodorsal. So this is a five one. From the medial cord also again there are five. So it is very easy to remember. So there's a terminal branch is the medial root of the medial nerve, ulnar nerve, and there are three. There's a medial cutaneous nerve of forearm, medial cutaneous nerve of arm, and also the medial pectoral. Now, another important, we have to identify the M pattern. When there is a chance of, where there is a dissection is required during brachial plexus injury, so it is very difficult to identify the different branches. So only the surgeon will find out the M pattern. What is M pattern? See, this is the M pattern. So this is the M pattern, it remains constant. So this is a musculocutaneous, medial root of median, lateral root of median nerve, medial root of median nerve, and the ulnar. They will remain a constant M pattern. So this is very easy to remember. Now again, so suppose this is the telephone number, is that a landline number like that. So from the last development, all the landline number is added with initial prefix 2. So this is the two branches, they are coming from the root. So what is the one is a dorsal scapular, this is coming from the C5, whereas the nerve to, there is a long thoracic nerve of Bell, there is say it is coming from the C5, C6, and C7. So it is by now, it is a this number. If you remember this number, 25363 and prefix 25363 it is now very easy to remember different telephone number. So if it is very easy to memorize. Now the OPD, so now we have to take a short history relevant to the point examination. See, suppose in the very busy OPD, so how to write it? It's a very short history, as you can see here. It's a low back pain 4 years with left sciatica and neck ache for 4 years. Relevant to the point examination, this is the relevant to the, you can draw like this. So you have to write this like this, and the provisional diagnosis is see, this is the SLR, it is the left side is 60° positive. So the lumbocercal spondylosis with canals compromise basically. So in you have to write out the investigations, LS spine epilateral, and have to make a rehabilitation, medicine, and prognosis. You have to make a prognosis. So it is whether it is relieved or not, and you have to make a date of review. Now from that you have to understand, you have to make a aim in objective in every OPD, that we have to examine whole completely of a spine case, of a hip case, on a large joint, and also the small joints. So you have to make at least complete at least 20 large joint, 20 hip examination, 20 knee examination, 20 elbow examination in your 3-year period. So you'll become the master of this examination. So if you make in this manner, it will become a master. Now, from the OPD is another source of chronic cases. So apart from the large joints, you have the acute cases like the examination of the emergency patients. So it's orthopedic emergency, and you have to know this ATLS and BLS. It is extremely free from the internet. So this is the I took this internet from the internet. So ATLS it is a extremely elaborated information we will get from this ATLS protocol, and you can be very much corrected, make rectified from your seniors. And this is basic life support. These are two manual. One you can buy, another will be absolutely free. Now, the art of triage, it's also have to understand if it's a bulk of patient has come in your emergency or the OPD, you have to how to try make a triage. You have to understand from the, so from that you have to make the source of read in your theory examination. So triage, have the color code, the different examinations, the primary survey, secondary survey. So everything you have to understand. Two books which will help you. This one is a Bonsetti monogram, another is the Close Treatment of Common Fractures, John Charley. Class studying is a forgotten art, but you have to become the master of that art. Now, this is the ABCD of the radiograph in the radiograph. That is what is the ABCD of the radiograph? A for is basically it is the age. So you have to understand what is, whether it is a mature radiograph a mature or a immature. Another is it is the whether it is adequate or not. See that the different radiographs are there. Whether the only adequate radiograph is on this one and this one, because any long bone should have the joint proximal and the joint distal. Now next is the BC, that is the background and the background of clinical information is very important. B and C is a background of clinical information is very important. And D for the basically is a deformity or the date, whether it's a fresh radiograph or a old radiograph. This A, B, C, D is a very important. And now there's a basic. So what is the difference between the angulation and the tilt? Angulation is the this is the basically this is the angle formed between the two fracture fragments. Suppose this is this is anterior and this is the posterior. So this is the patella. So this is the anterior angulation. Now see the patella. This is a posterior angulation. But for the fracture of the which close to the fracture close to the articular surface, this angulatory movement, angulatory displacement is not diagnosed, not uttered as a angulation, but it is as a tilt. What is tilt? Tilt is basically it's the direction of the articular surface of the distal fragment. See, this articular surface is directed towards, see, this is a thumb. So it is a lateral one. So it is lateral tilted. So this is the difference between the angulation and tilt. So this sort of basic information you have to understand. See, this is the posterior tilt. So of any Colles fracture, there is a always there is a lateral tilt, lateral tilt, dorsal shape, dorsal tilt, and the impaction. So everything. So this is the way we have to understand what is the tilt and the angulation. Now, why it is tilt and angulation is given? For the angulation, it requires a longer arm. So for a better appreciation of the angle, and let's see the direction of the angle, it is your angulation. So direction is a posterior, so it is a posterior angle. Direction is the anterior. It is the arrow is looking towards the anterior, so it is anterior angulation. And the for the tilt, as the fracture is very close to the articular surface, so one arm is very long. You can tell if it is take a longer full length radiograph. Another arm is very short. That's angulation is not called. This is the basics. Now, this the advance of the radiograph is different lines and angle, like the Bowman's angle. I'm not going to detail, and the metaphysical diaphysial angle. Now, how to identify this metaphysical? This is very, very important. This is for supracondylar. This is the metaphysical line. So in the now the spot OPD. Now, what is the playing? See, this is the how beginning of the, so this where this is, see this the to identify this what the exact operation done is have to exact what is the meaning, what is the exact operation done. This is soap kapanji technique. Now, preparation of the operation. In the operation day, we have to make a plan. The preoperative checkup, anesthetic fitness, position of the patient and the limb, approach, incision, muscle interval, and specific in technique. Now, I will guide how to proceed for that. Now, basically, you have to understand how to prescribe the implants. It is very, very important. Now, the books will help you before your operation day. These are the books. There is again, there is a Hoppenfeld, there is a Campbell's. There are two books. One is I think everybody read this the Campbell's book, and this is the core orthopedic procedures. And this is very, very useful. This is AO manual before OT day. It is extremely helpful. Now I'm giving an example: the surgical approach to the hip. See, there are several topics, the anterior approach, anterolateral approach, lateral approach. There are several lateral approach you can see here. Now, it is very difficult to say if you become the master of this diagram, you can draw this, but I'll show how to make your life very easier. Now, there are several other approach like posterolateral approach, posterior, medial approach, anteromedial approach, combined anterior and posterior approach. Now, I'm giving very easier way by which everything if you conglomerate. Now, if you see the anatomy of the hip, the first layer from the anterior from posterior to anterior is the gluteus maximus, laterally fascia lata, anterior is the TFL and the sartorius. The second layer muscles is the lateral rotators from the posterior, and the lateral side is gluteus medius minimus or the greater trochanter, and the anteriorly there is the rectus femoris. Now the approach is, now see, this is the anterior, it is in between this TFL sartorius. So this is the first layer, it is in between two, then the second layer in between two, direct to the hip joint. Now the lateral, if it in this way, so you have to divide the fascia lata. You can divide the gluteus medius and minimus directly the trochanter flip approach and up to the hip joint. Now posterior from the you have to split the gluteus maximus. You have to make the cut the rotator and directly go to the hip joint. So in this way you can easily understand. Now you have to, in the OT, we have to read the instruments and biomechanics. You have to name parts, use, and the modification and limitation. So can you identify this? So this one is the 1/3 3.5 mm semi. It's a semitubular, or maybe 1/3 tubular. So you have to check it from the side. Now this one is a recon, and this one is the LCP with combi hole. We have to know everything. Now the book which help in become the master of these implants. It is a Indian author. It is I also in the student. I read it. It is extremely helpful book for the implantology. Another is a recon plate. You can see here, just I'm giving the example, these two recon plate. This recon plate is used for the pelvis. It is a very tough one, but there is no locking hole. But because in pelvic fracture, preferably the locking should be avoided, as the tactile feeling is extremely crucial for the screw purchase. So this is the technical point we have to become master. Now, what is this? Is a DCP. Now, is it a misnomer? Is it a rightly nomenclatured, or is it a misnomer? Basically, it is a misnomer. You see, it is written as dynamic compression plate. But see, can you provide the dynamic compression even after the operation? No, it is provides the compression only during the operation. So the actual dynamic compression plate, which was actually evolved, it is the Eggers plate. Now it is out of fashion. Now it is a dynamic compression plate. It gives only the compression during the operation, but after the operation, it cannot provide the dynamic compression. So in that sense, it is a misnomer. That can cause self-compression plate. Now, in that sense, you have to give the recent advances. What is the angle stable locking screws? As you can see here, the three sets of hole with a sleeve, which can provide extremely locking inside the nail. That is more important. Now, in the follow-up clinic, this is there are different types of cases. You can see this is the typical club foot. You can see here, but see, this is not a typical. It is a boat-shaped foot. Okay, so this is basically is a rocker bottom foot. As you can see, the congenital vertical talus. Whereas see, this is not at actual, it is a CTV. What is that? It is basically, it is you can see here, this is, it is a basically, is a jet shaped foot. As you can see here, and this is another foot. As you can see here, there is a dropped toe sign. This is a CTV, is a specialized type of CTV, where there is drop toe sign, as you can see here. So this is a neurogenic club foot. Now, thorough clinical examination can be done only in the on the word, as you can see here, which type of gait it is. As you can see here, what type of gait in your word, you can see here. See these the lower limb. It is shortened. So there's a shortening, as also the trunk is it is moving. It is side by side in like a like the old clock. So basically, it is a combination of the short limb gait as also the Trendelbach gait. Now, from where did you read? So there are several clinical or examination book so from the Hoppenfield, as also the Macri. It is extremely good book, apart from the Esdas's book. And the apply is extremely very good. Is extremely informative in every sentence. We have to read very carefully from the pediatrics, Sharad, and for the fractures, it is a Rockwood Grain. And tuberculosis is the legendary Dr. Tuli is the teacher of the teachers. You must read it, and you have to know the National Tuberculosis Elimination Program, which is absolutely free from the internet. Now, from the word also, you can generate the topics for to read for your OSCE. So this is the traction system. From there, this is the sample example of the OSCE system. So exact site of insertion of the traction pin, which soft tissue complication will you expect from the improper padding of the splint. So you can see here. So this is the ulcer. Can also, there are some superficial peroneal palsy. You can see here. Is the traction is working properly or not? If is yes or no, you have to explain it. Now, what are the different type of knots you can use? This is that can be sailor's knot or the reef knot, or the different types of clover hitch knot. Which type of knot you have to understand? Now, this is very important even in your word round. Now, this is from the word also, you can have a generate your interest for to read like this. This 11 years old boy presented with limping and unable to cross leg, provisionally diagnosed the Perthes disease. See that which diagram, two diagram, what does it speak? Basically, see the abduction, and this abduction is limited when it is flexed. So flexion in abduction is limited. That indicates it is a sectorial sign, which is basically it's a suggestive of the Perthes disease. So in this way, there are several questions can be asked. Now, clinical presentation, we have to make a list like the long case and the short case from the hip. So these are the different types of list, and we have to identify in the broad category of the disease from when you examine it in your OPD and the ward. That's whether it is a case of traumatic disease, infective disease, deformity, neoplastic disease, neurology, congenital, like that. How will you identify? So this is the 7 basic questions. So starting, side, symptoms, span, sporadicity, spread, and the severity. Suppose it's a rheumatoid. Rheumatoid is basically is a chronic disease. It may be multiple site is involved. So there is a pain, stiffness, everything will be there. Span maybe it is a long span. Sporadicity will be there, waxing and waning. And if it is secondarily infected, it may be progressive. And severity, if it is a long period, suppose it is a secondarily infected, and then that may be several complication also. So these are 7 S questions. This, if you ask in your history, can be easily identified. Now, neurology, see, the different scales are there. You have to know the neurology, MRC grade, that you can see here. And for the spasticity, it's the modified Ashworth scale. This is the very, very basic books, Kendall's muscle testing functions. Now I am trying to make your life easier. See how to memorize. Now, this is the root value of the motor. C5, C6 is it is a 7. It is looking like 6. So it is all this you can see here, and this sensation is this part of the body. It is contributed by C5, C6 sensation. And the 7, it is looking like 7, and the sensory is contributed by the middle finger. And this all the movements. This is the triceps is C7 like this. Now C8, there is a grip. It is a C8, and it is a T1. This is abduction. This is side to side abduction. So if we make a side to side movement, so it is a T1. Now neurology, so it's a 2, 3, 3, 4, 4, 5. If the hip flexion, knee extension, and the dorsiflexion, and the EHL. And it's just opposite is just you have to the other one. L2, 3, opposite is the 3, 4, 5. 3, 4, and the knee flexion is the 5, 1. The dorsiflexion is L4, so this is a plantar flexion, it is L5 S1. EHL is L5, so the FHL, it is S1. Now, how do I identify the jerks? Jerks is 1, 2, 3, 4, 5. So I can make a rhyme. 1, 2, buckle my shoe. So this is the ankle. 3, 4 is kick the door. That means the knee jerk. 5, 6, pick up the sticks from the table. Pick up the sticks. That is the biceps. And 7, 8, lay them straight. That means the triceps. See, this is the root value of the jerks. So you can easily identify. Now, viva voce of the orthopedics, the nomenclature, parts, how to wear, indication, limitation, and complications. The orthosis classification is very easy. They have to make the joint, the orthosis which encompasses the joint. If it encompasses the foot, it is a foot orthosis. Ankle and foot, ankle foot orthosis, like this. If it is a cervical orthosis. If it is a Milwaukee is a cervico-thoraco-lumbosacral orthosis, like this. It is very easy. Now, indications of the orthosis is wild nomenclature. W for the weakness. That is a neurological neural palsy. This is upper motor, lower motor. I for the insensible. Okay. L for the loss of structural integrity. If suppose there is a multiple after multiple injury or multiple operation, there is a loss of bone at the loss of bone of the tibia. Even after that, we can patient make the mobile with the help of the orthosis. And D for the deformity. So the flexible deformity, dynamic deformity. This is a wild. So you can remember, you can easily. Now there are the name, parts, indications. The book which will help. It is Stewart's book. Now specimen, the microscopic specimen. Most of the cases it is given microscopic. So microscopic, basically there are different malignant tumor. You have to identify the parent bone, identify the lesion, nature and the location, the type of the sequestrum. You have to, if it is spine, you have to identify which area of the spine, cervical, dorsal, lumbar. We have to locate the disease, inferior, the infection or the neoplastic, how much vertebra is involved. If it is a microscopic, suppose it is a giant cell, suppose it is a Langhans type of giant cell, it is focused on your microscope. So it basically it is a multiple nucleated giant cells. It is in a U-shaped manner. Nucleus are situated in the periphery. So in this way, we have to identify. So this is, suppose this is the example. We have to identify the bone, in which type of sequestrum it is, what is the fate of the sequestrum, how you diagnose, and the management. Now the different research question, I am just touching in. This is a very it is a very vast topic. We have to make a different read in this manner. Types of the research, variables, samples, sampling technique like this, and the recent advances. There are several recent advances. It is the fourth paper of your theory. You have to read it. Like robotics, it is very coming in a very big way. Stem cell therapy, 3D printing, everything. Now, the take-home message, we'll take some questions. If we want, we can elaborate again. Now, take-home message. So, all PGT, postgraduate trainees have to know yourself first, your course and the facility. That means what to read. It lies in them. You have to plan, plan, and plan. You have to plan. Otherwise, without plan, you are planned to fail. So you have to plan yourself to customize your plan. Next is the personalize the information and the experience according to your understanding. If there is a problem, or apart from the how, when, and what, you have to add another objective is why it is happening. Why it is happening, it is very, very important. Implement the plan in due course of time. If there is a problem, again, you have to understand, you have to ask your seniors, teachers, colleagues, everybody. Read when you get scope. You have to write and say systemize. That is how, this is how we have to do, how to read. You have to learn by yourself. So mark every new things. That means the word, read for the details and the clarification. Not only that, this is a very, very important last line. Read for the point why. Sir, sir, you have told this, why it has had happened, please explain this. This is even I may not know everything. So if my postgraduate, my next generation maybe like a son, he may ask the question, sir, why you are telling? So that will generate the question, generate the stimulation inside me to learn. So this is the very, very important. Thank you. I think over to Ravi, and there is several questions we can discuss.
Thank you, sir, for wonderful talk. And I would like to invite the expert panel for the question. And by that time, Ravi, there is one
Uh,
question in the chat box, sir.
yeah,
Yes,
sir.
Ravi.
Actually, one of the PG wants to know that can you elaborate on ABCD of radiograph that you had
Yes,
just taken up
yes,
in your
yes.
slide, actually.
Yes, ABCD, basically A for the adequacy of the radiograph. Adequacy means that is any long bone radiograph that may require at least two view, that is the anteroposterior and the lateral view. There are two joints, joint proximal and joint distal. Maybe in two occasions. Suppose it's a scaphoid, it may require two occasions for diagnosis. So at least it has a two views and two joints, any long bone. So this is the adequacy, first one. Then next is the age. Once we get the radiograph, we have to understand whether it's a radiograph of a mature or the immature. So there is evidence of the epiphyseal line. And B and C is the background of clinical examination. Background of the clinical or the body of the radiograph. Body of the radiograph. So background of clinical means every radiograph tells some history. So that is why in the pathology they need some history. Always once we send the specimen, they need some history. Similarly, any radiograph has some clinical history. So if it is better if we know the clinical history, otherwise the body of the radiograph, that means we have to read from the periphery to center, center to periphery. Periphery center means this soft tissue, from the soft tissue, abnormal soft tissue, next the extracortical shadow, then the cortex, then the medulla, then the joint, like this systemically. Suppose the hip joint, you may come from the above down or from below up. From the above down, you have to check the acetabulum, then the joint, then the femoral head. Femoral head, that is the physis, if there is some chilus or not, the inside the come inside the physis, if there is subchondral cyst, subchondral sclerosis, and then there's a metaphyseal region, then the neck shaft angle, the neck that shaped when the neck is short or broad, like the deform, that is coxa vara, coxa valga, like this. So in this way, you have to body of the radiograph. And lastly, D for the deformity and the date. Deformity means apart from the joint bone, we have to check the joint, if the joint alignment is good or not. Suppose a standard radiograph of the pelvis, it must have two hip joints symmetrically. How to know it's a anteroposterior standard AP view? You have there is the coccyx will touch the symphysis pelvis, and there is symmetrical shadow of the obturator foramen. This is the standard anteroposterior. So that is why for the comparison of the two sides, for the alignment and the deformity. So this is simple level deformity, subtle deformity can be easily diagnosed. So this is the ABCD of the radiograph.
Thank you, sir. Thank you. Any other question from any of the panelists or anybody from? Or we can go through
Lalit
some.
Mani sir, Jayant Sharma sir, Jayant Sharma sir.
Jayant sir?
Yes.
Sir? Or else we are having.
I don't have a question, but I just want to suggest something.
Yes.
I want to tell the students that they should carry a handbook of Cowell in their aprons whenever they are in the OPD or in the ward. Secondly, ideally, it should be that they should have a digital. I mean, nowadays the mobile cameras are good. Our times it was a camera. We used to take pictures of those rare conditions that we used to come across in the OPDs. Thirdly, we were advised by a professor, our another teacher of teachers, Professor Taneja, that on your history sheet, I mean the examination sheet, everything that you're having in the wards, you should write down the classification. That way you remember the classification by the time you go in the third year. So if you're seeing a fractured trochanter, try to classify it, put it on the paper, so that makes a habit of reading the classification and remembering it at the time of examination. This is what I was wanting to share with you people.
Yeah.
Thank you. I think we'll discuss
Yeah.
again how to make your kit ready before examination. And,
That's very
a future class is a
that's
very
Magu, sir.
important, Dr. Pal.
yes, sir.
Yes, sir.
Jayant has definitely, I want to emphasize it. See, you have to define your kit as you are mentioning. So
Absolutely.
camera and stethoscope these days are the essential tools, and you must carry, a postgraduate must carry in his briefcase. The camera, I mean, and classification third thing, I used to tell my postgraduates that they must carry the leaflet of various classifications, particularly the firstly, it is difficult to remember all these classifications. But if you analyze every case in the ward or in emergency, you will never forget the classification.
Lalit
So
sir,
that, yes.
Lalit sir, are you there? Can I have one
Yes, sir.
question from you that during even from the since long years, it has been seen that PGs are always have one thing in their whenever we say that go and study, so they have this answer that's a duty pe kaam bahut tha. So what are your suggestions that how the PGs should balance their time management with their clinical reading materials as well? How they can balance the reading as well as the clinical duties? So what are your suggestions for the PGs?
So I think it is important to understand the go. So go does not mean that you go back home and study. So it's a residency program and it's adult education. So it's on the go. And as and when you get your cases, whether it is OPD or the emergency or the ward, I think the learning starts from the patient. And once you start your residency, you don't know anything about it. So you open a book. Nowadays, all the postgraduates are carrying an iPad and they have a book, all the books on the iPad. So I think it has to be on the go. And during the emergency and during the ward duties, they have to be reading about the various cases that they see. And every time they see a case, like Dr. Magu said, try to get them into a classification, and then by the end of 3 years, they would sort of remember most of them and understand their application. So go is not go home. Go is keep reading and learning as you're working in the ward.
Thank you, sir. And in continuation to that, sir, you have a lot of experience in various journals. You have been the editor for IGO for last 6 years. So what you suggest to the residents that in reading their habits, in reading habits, how they can balance the reading books as well as the updating themselves with the journals. So what are those journals that are basically must to read for them, or what are those articles, how they can balance these updating themselves with the current research and keeping themselves with the books as well.
So that's a tough task actually. The challenge is to keeping up reading the standard textbook itself, the books that Dr. Paul have suggested. I think the postgraduates are still, struggling to even go through all those books. But yes, the right way is that you should update your knowledge about cases, reading journals, because what is the difference? Literature comes into a textbook after around 5 to 7 years of getting established. So what is new would be available in a journal. So for a postgraduate, as he is developing, probably the best time to read a journal is when he's going to present a seminar, or when he looks at a peculiar type of a different case, or he is actually presenting a journal club. And if you ask me what could be the 5 journals which somebody should have a practice of looking into, would be the Indian Journal of Orthopedics. You can choose one trauma journal, like the Journal of Orthopedic Trauma. Then we could use a very broad-based journal, the Clinical Orthopedic and Related Research, and then the two JBJs, the Bone and Joint Journal from the British and the JBJS American. So if you can keep peeping into these 5 journals off and on, gradually you'll develop the habit of reading the current literature.
Thank you, sir. Paul, sir, what are the specific books? Actually, you have suggested a lot of good books that you have gone through, or we have also gone through in our PG days or even residency days. So, what are the must-read books for the PGs? Actually, starting from the first year, going through the second and up to the final year, even in the senior residency as well.
So for the
So,
clinics, I
so
think this is Dash. This is the first one. This is a very, very basic. Next, the Macri. Macri is extremely important. Next is the Hoppenfield. This is the 3 books. I think it is a extremely must-read book. From the operative, this is the Campbell's and the Hoppenfield's approach. The approach is this anatomical approach. This is extremely important. Hoppenfield's approach and the Campbell and the AO manual. This is, I think, it is very, very important. And for the orthosis processes, it is that is the only one that book I showed it. That is the and that's the Chandler's plaster techniques.
For orthotics, Stewart and Hallett.
Stuart, yes, Stuart. I think these are the basic books everybody should read.
Okay. Thank you, sir. Rajeev, sir, I have one question to you as well. That nowadays there are a lot of subspecialties. So a lot of PGs do have in their minds that we need to go for scopy, we need to go for plasty, and even from the second year onwards, they start thinking of those specialties instead of spending their time in understanding the basic concepts of orthopedics. So what are your suggestions? You are a specialized arthroscopic surgeon. So what are your suggestions that what's the right time to move into the subspecialties and how they should channelize themselves during the PG as well, or even after the PG?
Very nice question, Ravi. And I think this is a very important thing we are facing in our day-to-day practice and fellowship program also. So residency is not for specializing yourself. You should know everything. You should know about trauma, arthroscopy, arthroplasty, spine, everything, deformity correction. And then after doing your completing your residency, you should go for your senior residency. Complete your senior residency for 3 years, and then after completing your senior residency program, plan for your super specialty or subspecialty in which subspecialty you want to go. So during PG, yes, you may develop interest in that particular, suppose arthroscopy, arthroplasty, or spine, but I think that is not the right time to choose your subspecialty. So try to, and if you see the Western training program, they are for 6 or 7 years. So after 7 years only, they ask you or they suggest you to choose your subspecialty, or you are consultant after 7 or 8 years of training program. So I think Indian training program is also designed like that. And in Delhi, I think it's very common to complete your residency, then you complete your SRC, and then you plan for your subspecialty or super specialty training program. And I think we have enough fellowship opportunity in India and abroad. And after doing that, you can start your subspecialty practice.
Thank you, sir. So definitely you have
Can I
given
add
the
something,
answer
sir?
that, yeah,
Yes, sir.
Lalit, sir,
Lalit
you want
Mani,
to say
sir.
something?
Yeah.
Sir, you want
So
to
I
say
think more than the PGs, it is the units that they are working in. So now, if you see most of the medical colleges, there is an unwritten, subspecialty work going on in different units. So this exposure of specialty work happens very early in post graduation. So in institutes where there is no rotation, and I can tell you that rotation is not a common thing which is happening in orthopedic PG training in most of the institutes. So the PG actually gets stuck with a particular subspecialty, and that's a challenge that to give them a complete exposure. And if you ask me what is the right time of start thinking about a subspecialty, it is the second year of senior residency. That is just the time you start thinking about it. Otherwise, the base has to be very broad so that you are, able to take care of the whole gamut of problems which you face even when you reach a subspecialty.
Thank you, sir.
So I think for the post-graduation time, you should be focusing on, understanding everything and looking at everything.
Thank you, sir. Actually, both of you, Rajeev sir, and you have excellently answered basically, this is the crux of the issues nowadays. Because even during the residency, their PG days, and even just after completing their PG, they move to work fellowships. So ultimately, they lack the basic understanding of orthopedics. So that's the major concern nowadays, actually.
Yes.
So it has been rightly been explained by you and Rajeev sir. So one question, sir, Bhuwan sir, in this webinar also, and some of the residents who have not logged in, they must be watching it on, basically they can later watch it. So we'll share it with them. So a lot of them have rolled into from Bihar and from the remote areas, almost 30 or 40 registrations we get from the Bihar only.
Okay.
So what are your suggestions that there are certain postgraduates who are from the basically backward areas of Purvanchal, UP or remote areas of Bihar, and they have taken their education in their basic languages. So when they move to a medical college, so and they suddenly they find that they are moving into the English curriculum or some sort of that kind of a curriculum. So what are your suggestions how they should cope up with those challenges?
No. He should be adopted with the regular process of the teaching. And this is very nice start, I think so. This is very good. One of the PGs beside me, Dr. Avinash is here, and he prays very much. And everyone adapted, we should advertise it to the medical colleges. And I will talk personally to 5 to 6 medical colleges for this webinar only. And for next webinar, the date will be disclosed by you. Then I will advertise, and I think about 50 to 60 PG will attend in the next webinar.
Thank you, sir. Thank you. Paul, sir, you have just touched that topic of OSCE and the current curriculum of the DNB, actually.
Yes.
So what are your suggestions that how the PGs should balance themselves in OSCE and the table vivas during their practical exam? Because a lot of PGs have a lot of questions that we can do better in the table viva, but they are having a fear of doing better in OSCE because they don't know questions and the kind of questions and the toughness level of those questions. So what are your suggestions to those PGs who have a fear of that kind?
Absolutely. It's a very, very important platform that every PG should understand what is the difference between a physical exam and the OSCE. Basically, we can take the separate classes on this in this platform on the OSCE. I have also prepared on them. So basically, OSCE, there are several types of OSCE. Most commonly, there are maybe descriptive type or maybe analytic type. In descriptive type, just I have shown it, just like a simple gate. So this is the gait we have to understand. So what is the, we have to notice it properly. So from systemically from the head, shoulder, what is the exactly is going on? We have to diagnose. This is a descriptive. Analytic means there are some problem is given and have to analysis. So this is so I have already shown it from the OPD, from your word, from your OT. So you have to your personalize your problem. So you have to always, as Dr. Magu has suggested, so we have to classify. How to classify? So always once to get a patient, so always consider whether it is a traumatic disease, it is an infective disease, inflammatory disease, neoplastic disease. Always once you check any patient, first we broadly categorize. Then we have to make. Suppose it is a traumatic, so there must be history of trauma. There is a loss of pain, function and the painful swelling immediately after the trauma. So there be significant trauma, that may be trivial trauma, that may be repeated trauma. But that is for becoming a traumatic disease, the incident must start immediately after the trauma. It may not be from past history. So this is the one. Infective, there must, suppose it is a pyogenic, there must be history of some pyogenic. That means the history of discharge or in say operation like that. So this is the specific history. So you have to broadly categorize, classify the disease. Then once you become bad, it's an infective disease, then it may be whether it's a pyogenic or is it tubercular. So in this way you have to think of. And so there, if it is a OSCE system, then if it is easy to understand which type of it is analytical. So it is after analysis is done, it is a infective disease. Analysis after analysis, you have to understand it is a traumatic disease like that. Is the physical examination. Now it is straightforward. You can, if you fail it, examiner may give you the second chance. So that is a great opportunity. But in OSCE, you will not get a second chance. Time is fixed. You have to understand. So you have to train yourself in this manner, as Dr. Magu and other seniors has suggested. Classify the disease, broadly categorize, and after that you have to know which type of disease, provisional diagnosis from every steps.
Thank you, sir. Thanks
So
for
Ravi,
the
one comment here.
Yeah, sir, please, sir.
I think it is very important to speak. So if you have to get away from the fear of table vivas or presenting a short case or a long case, you have to practice speaking throughout your residency from first year to third year. That is what happens in rounds. Classically in rounds, you're asked things and you speak out, and invariably you're pulled on it. Now, there are two parts to it. One is you're trained to speak. That means you're trained to communicate regarding the patient or regarding a problem or regarding the knowledge you have a particular scenario. And the second thing is when you're pulled, it is, you're stimulated on your analytical capabilities, on how logically you can address when you're counter checked on a response. So the best thing is to speak in 3 years, make as many mistakes as you can while speaking, and then you'll become a master like Ravi is on speaking on a forum. So it is like a stage fear. So if you practice more, you will do well. I think what happens is they have a mind block. They have a mind block in the exam at various levels, whether it is a viva or a table viva or even answering a OSCE. So these mind blocks will become less if they practice more often speaking. So please speak.
Thank you, sir.
Excellent
Thanks
tip.
a lot.
Excellent
Many
tip.
questions have been addressed as far as this post-graduate examination is concerned. I think this 3 years period is learning basics.
Sir, can I have your video, Magu, sir?
Okay. This 3 years period, I'm visible now,
Yeah, sir, please.
is basically learning your orthopedics and then becoming a master. So you must stick to the basics. I think history taking is very important. We used to attend classes when Dr. Maini was taking undergrad classes or my other teachers were taking in early days. So one postgraduate should be able to make some kind of a diagnosis just on history. So history taking is very important. Then he should think of what could be the differential possibilities as far as this patient is concerned. Every patient is a new patient. Second is the art of examination. That's again very important. So if a postgraduate is able to take a good history, make a differential diagnosis, do a good clinical examination, I think he has earned what he wanted to do during post-graduation. That is what I want to emphasize. That is very important.
Thank you,
And
sir.
patient is your teacher. Teacher is your guide. Whatever my teacher used to say, whatever patient tells, that is true. You should believe that. But if it is a pain or there is a limp, if the limp came first or the pain came first, patient is correct and you must enter your diary. So these two things I want to emphasize again. Regarding recent advances, I think daily teaching and group discussion, मुझको अब भी याद नहीं है ये ब्रेकियल प्लेक्सस फाइनली कैसे जाता है. But if you discuss it with case and more frequently, a resident must know the variety and number of cases which he is going to examine in a medical college. He will not see that. He will see very rarely in practice or whenever he joins job. So this is a dedicated period of the resident. He must understand कि भाई ये 8 घंटे की ड्यूटी जरूरी नहीं है, ज्यादा करोगे. This 8-hour duty or shift is bad for learning for the postgraduate. If he has taken his dinner, he must come to the ward and complete his work. So that is what I would say a postgraduate learning means. It is a brahmacharya kind of the medical science, which I should say.
Thank
That
you.
is what I want to emphasize.
Thank you, sir. I have one or two more questions, Paul sir, Magu sir, and Lalit sir, and Jayant sir as well. That regarding the biomechanics. So PGs do have a fear that what are the things that we should know about the biomechanics of joints and from where to read. So what are your suggestions? Is there any specific book they can consider of, or are there any specific methods they can go through, or to what extent in understanding the biomechanics they should go for? Because what an examiner expects them from, that regarding the biomechanics of various joints especially, and what are those joints specifically that examiner wants to know A to Z from the PG, that this joint is must for you to understand the whole biomechanics. You can be spared of understanding this joint, but you can't be spared of if not understanding this joint. So
hip is a very common joint, you see, and
yes,
a resident will definitely get a case in his examination if case is there in the ward.
okay.
So he again should stick to the basics. What is body lever arm? What is muscle lever arm? What is mechanical access? What is mechanical
he should be
access?
knowing, he should be knowing at least 80 to 90% of the hip biomechanics, which is very important.
This is very important. And to say that he is to learn biomechanics of every joint, it's really difficult. He will learn with time. And the more and more interest he does with super specialties, he will definitely learn.
Absolutely. So actually biomechanics of hip must be there, and spine, shoulder, and also there are large joints. So this is most important. And the biomechanics of the implant, this is very, very important. We have to understand. And I've already mentioned there is a Anand Thakur. He has written a very, very good book on that. So everybody should go through it. And there is another book on the implantology. It is recently published by Springer Verlag. There's books on implantology. This is also a very, very good book. So the very basic things are discussed, which is relevant in our day-to-day practice. So this yeah. So just one thing, just this I just why the cane is important to use after the hemiarthroplasty. That is relevant in biomechanics. So this is the way by which learn. So every postgraduate should learn. This is the question which remain inside me, and I didn't get the answer till my postgraduation period. Even after long time after the passing, so we have to make it physical. We have to go to the physics teacher to understand why the cane helped in relief of this joint reaction force. So this is a very, very important, I think.
Okay. And sir, regarding the use of cane in the knee injury, a lot of PGs have this dilemma that in hip we can understand, because in books hip is written, but about the knee is very less is written. So
Yes.
what are your suggestions regarding
These suggestions are the same, I tell you.
Yeah.
Yes.
Whether the pain is on the hip or is the pain in the knee. So you have to carry the cane in the opposite hand. I also used to ask this question and used to guess his impression When pain in the knee, carry the stick on the same side. When pain is in the hip, carry the stick on the opposite side. That is wrong, I think. In terms of biomechanics, you have to put your body weight through the gravity it should pass, as close to gravity as possible. So that way you have to carry the stick in the opposite hand.
Absolutely right, sir. This is the so it was a misconfusion inside me also. So before I just that is why I highlighted this point. So whether you have to carry on the painful side or not, the biomechanical should be always be carried on the opposite side. This is the message. It's a very, very important. I think. Thank you, sir. Thank you, sir, for this.
Thank you, sir. So I think all our faculty have answered the basic questions of what we should know during our orthopedic residency, when to read, what to read, and definitely the questions can be endless because there are different specific topics and a lot of questions can arise from there. So I really thank all of our faculty members, Paul sir, Lalit sir, Jayant sir, Magu sir, Ranjit sir, who have spared their valuable time for us, and especially not last but not the least to Bhuwan sir, who has given the opportunity to start this platform, and definitely it will benefit a lot of postgraduates throughout the states of our country. Thank you, sir.